All right. Hello and welcome, everybody, to today's event, Telehealth Advocacy and Navigating the New Frontiers of Healthcare Policy, and more specifically, telemedicine policy. We have a little bit of a change in format for today's event. We are going to do more of a podcast style type of event with our amazing guest, who I'll introduce here in a moment. And we're going to be covering a lot of exciting topics today. So the agenda, we're going to be talking about some of the existing telehealth legislation that's been passed and how that might lead to more permanent legislation. We're going to talk about some of the legislation that's active in Congress, and there's a lot of it. We're going to touch on the DEA and their temporary rule around prescribing and telemedicine. We have the proposed physician fee schedule for 2024 that was just released by CMS. So we're going to cover some of the telehealth specific pieces of that for everybody on the call today. And then we're going to talk about the AMA and some of the new telemedicine codes, how that might affect payment parity, and sort of discuss maybe how to get involved with how active the landscape is for telehealth legislation. And then finally, at the end, we will open it up for Q&A. So in Zoom, there is a Q&A tool. Feel free to use that at any time to enter your questions. And then when we get to the end of our agenda here, we'll start to sort through those questions, and John and I will field that. So let me introduce today's guest and good friend of mine, Mr. John Ralston. John brings over 25 years of robust experience in public affairs, government relations, and grassroots advocacy. He is the current president and founder of Armory Hill Advocates, and has dedicated his career to service in national law firms and across different large healthcare organizations. And I think some of his, at least, his experience that's kind of cool, a little bit more fascinating to me is John served on the administrations for George H.W. Bush and Ronald Reagan. And John has directed the development of 2 national trade associations for healthcare, has been a former chairman of East Central Florida, a regional planning council, is a recognized a frequent speaker on the Medicare prescription drug benefit program. It seems like I could just go on and on, John, and you might prefer that I keep going, but welcome to the webinar today, and we're extremely excited to have you.
Great to be here. Thanks, Matt. You didn't have to go through all of that. It's okay.
Well, cool. Well, let's start to jump right into this. So, first thing I want to touch on is the 151-day extension and the most recent extension through 2024. But I want to back up for a little bit. I think during the pandemic, we saw 30 senators sign on to a bill for permanent telehealth legislation, and which I think is pretty unusual. It's kind of unusual to have bipartisan support on an issue, but to have 30 out of 100 senators, it seems like there was support for permanent telehealth legislation, but it just seems like we're just taking steps, right? We got a 151-day extension. We have an extension through 2024. If maybe you can sort of describe a little bit why we appear to be taking these steps instead of, having something permanent already.
Sure. So great to be here. Let me just say, first of all, to those of you who do shoulder surgeries, I've just had a repair of my supraspinatus in my rotator cuff, my left shoulder. So sorry, I'm in a sling today. But those of you that have been down this road before can sympathize. So it's not a fun experience, but great to be here. So, Congress moves really slowly traditionally. State legislatures typically move much, much faster. The Congress just moves slowly. And so when you think about the environment we had prior to COVID, really telehealth only existed in those rural states, right? It was a benefit extended to folks who lived in rural states and had difficulties getting to providers on a regular basis. And some of those rural states had all kinds of issues in terms of broadband access. And so, you had the Congress, you had Indian tribes, a few others in those difficult rural large states with lower populations, more centered around making sure that Medicare was providing services to those types of patient population. So enter COVID 2020, right? And all of a sudden, you've got nobody seeing a doctor in person anymore. And if you do, it's crazy how you've got to get in the door to see one. You got to wear 3 masks and gloved and everything else. And so there was a sense of, all right, let's extend COVID through a regulatory rule action, through the president's emergency rule. At that time, it was President Trump, which covered the ability for CMS to extend coverage to all Medicare beneficiaries. Commercial insurance plans as well, across the country, actually said, we'll follow suit. We'll do the same thing. And we'll extend this to all of our, patient populations, and obviously state Medicaid programs did the same. So you have the 2-year period. And during that time, members of Congress are waking up. They're saying, gosh, I think we could use this. Maybe we should codify this. Maybe we should put this into United States statute and allow all beneficiaries to receive this going forward. We see a lot of benefit for this. So that kind of started slowly, and there were pieces of it. First, it was we need to make broadband more accessible. Now there's more of a reason to really step up and really get broadband moving in all these rural and other states that had gaps. So, and there was no argument. That was not even debated. And so everybody said, yep, let's jump on the board. Let's get moving on that. And over the course of the last 2 years, it seems like, more and more legislation has been introduced. I think I mentioned to you, Matt, that as of today, this morning, there are 11 bills currently been filed in the United States Congress, House and Senate that are pending, along with other regulatory rule actions. So 11 pieces of legislation moving, all hitting various stages of telemedicine, some overlapping, some not, and none of them have all of the pieces of the extension in there that CMS just issued. But at some point, they will all be included in an omnibus bill, and it'll be a telehealth piece, but that hasn't happened yet. So it's a long-winded answer for you.
Yeah. So what do you think? What do you think the holdup is for having something permanent? Why don't we have something permanent already?
The holdup is always the same, regardless of the issue. It's always the physical impact to the budget. It's always how much is this going to cost us? Right now, CMS has been gathering data. They've been looking at utilization data. They've been trying to determine are Medicare patients that are currently using telehealth, are they also going in person? Are they doing one for the other? Are they, is there an indication or a trend, in fact, in place where they can see trending and then begin to determine what that impact is going to be to the budget. Every piece of legislation that moves through Congress that's viable has to go through what we call a scoring process. There's a committee that reviews all of it, and actuaries and mathematicians that determine what's the impact going to be to the federal budget over a 5-year or a 10-year period. Most of the legislation that I've looked at recently that has a shot at making it, their scores are anywhere from 5 to 7 billion. The expectation is that this could be as much as $8 to $10 billion. So at that point, Congress has got to figure out, okay, that's real money. That's a significant impact to the federal budget. We have to figure out, number one, how we're going to pay for that. And then number two, how is it going to be implemented? Is it going to be implemented over a period of years, over time frame? And so there's a lot of moving parts that go into all of this, which is why you don't see an actual piece of legislation that says that's sailing through Congress right now.
Got it. So it's really trying to understand the costs and how are we going to pay? How are we going to pay for this?
Right.
What do you think? I mean, given that we saw the 151-day extension, we saw the extension through 2024. You've got all of this activity around telemedicine on the Hill right now. Is that a good sign or a bad sign for the prospects of seeing something permanent?
I think that's
someday?
a great sign. Yeah, I think it's a great sign. I know that, in preparation for this conversation today, I've had some meetings with the chairman of both health subcommittees on the House side. I think as some of your folks may know, healthcare legislation goes through 2 committees in the House and 2 committees in the Senate side. And they really, 2 of them are more focused on policy, and 2 of them are more focused on the fiscal impact to the federal budget. And so I talked to both of the subcommittee chair and the House side, and both of them understand the urgency, but doubt that there'll be anything done this year. There's just too much happening and for it to get done by the end of this year. Obviously, the extension's been granted to the end of 24. So there's going to be plenty of time to work on some of this legislation next year. However, keeping in mind that next year is a national election year.
Yeah, so some of these things, although with telehealth, they didn't tick down to the last hour of the 151-day extension. They did act well in advance of that. Next year is an election year, and so these extensions, the current extensions, go through 2024. What does with an election cycle next year, what's Congress likely to do? I mean, could they not do anything because we just had an election?
Right. So CMS often utilizes the physician fee schedule as a mechanism to do a lot of things because it's an annual piece of regulation that is the CMS issues every year. So, and it was a good vehicle. They've used it in the last 2 years for telemedicine regulation issues. So it was good for them to be using it for this purpose this year. I think whatever's going to, I would mention to you that there's one piece of legislation that actually could pass this year. Interestingly enough, there has been gathering some support for a telemedicine health plan bill that would allow for a telemedicine, telehealth health plan to be put up on the exchange where Obamacare is handled and be sold as an alternative to additional health plans. The federal government does not intend to subsidize it, but it is going to be a lower cost alternative for folks who believe that perhaps a 100% telehealth health plan is in their best interest. It's interesting to think about, because I don't believe you or I or anybody that we know gets a health plan based on the ability to not see a physician in person. But this is a highly sought after alternative, and CMS is very interested in it. The Congress is very interested in it. They just want to see if this thing's got legs. So this very well could pass, and we could see next year, sometime middle of next year, actually some type of health plan that allows physicians who are doing 100% telemedicine only, on the exchange. It's going to be weird. I don't know how you do that, but it's interesting to think about.
Yeah, I mean, it is actually something I've been kind of looking at myself. Could everything be done virtually? And it's interesting. I think if you go back to some of the origins of the Affordable Care Act, part of the problem was, how do we get everybody paying into the system, right? You have a lot of young, healthy, or maybe people who are in this gap of their employer doesn't offer it, but they don't qualify for Medicaid. They're not of an age to receive Medicare, and maybe they're not paying into the system. So how do we get everybody paying into the system? That seemed to be one fundamental problem that the Affordable Care Act was trying to address. Maybe this is a way. You have a lower cost option, and gets more people with some access to some sort of care that's not just an urgent care or something like that. But what is there? We also talked about, there's 11 active bills. Is there anything else noteworthy about the 11, or anything else on this potential to have a virtual only option in the exchange?
So I think in regards to the virtual only option, so my understanding is all of these will have some kind of catastrophic benefit in the back, right? So in the middle of an unforeseen catastrophic event, they're still covered in the ER. But the idea is to have folks having access to telehealth so they don't have to utilize the ER or urgent care, right, for doctor's appointments. And it does, it piques the interest of those folks that are that 26-year-old group that's rotating off their parents' plan up to the early mid 40s. They all think they're bulletproof and never get sick. And so that, could be an interesting alternative for, for that demographic. However, I think, in terms of looking at the variety of legislation that's out there right now, they're all looking at different pieces. There's one piece that looks just at parity, right? Wanting all providers to be paid the same for an in-office visit, regardless of whether that patient is in front of them in person or whether they're in front of them on a camera virtually. And so there's a discussion working its way around trying to determine, is that adequate? And Medicare and the state Medicaid programs are also trying to figure that out. How do we pay for this? It's a good, alternative, but should it be paid the same? And so they're weighing that out. One of the things that's most interesting, I had a discussion today with the owner of a hospice company in South Carolina, and they love the idea of having virtual health or virtual telehealth because of all the reasons that I'm sure many of your folks, feel the same, is that you've got a medical director that's serving 4, 5, 6 hospice entities or other, behavioral health type centers. And those nurses and folks can't get to every one of those in person every month. So in order to satisfy, Medicare guidelines, they want to be able to use a virtual visit in between, and will they be paid the same? And it's a great debate. It's a discussion worthy of debate. And so I think that's where some of the legislation looking at. Some of them are looking at, of course, the rural boundaries and doing array with the rural boundaries, so that it's just not, it's extensive for all, or included for everyone, regardless of where they live and their proximity to a physician. So, different things like that.
Yeah, payment parity is going to be huge. I know we're going to touch on that in a little bit, but let's switch gears to talk about the DEA. The DEA put a proposed rule out earlier this year. They had a comment period. There were just an overwhelming number of comments, and it was really about sort of forcing in-person requirements. It's kind of interesting, right? You got this piece of legislation that's maybe 100% virtual, and then the DEA was trying to force this in-person or this telehealth referral to establish an in-person provider, but then this other provider could be virtual. It almost got a sort of way too complex, and so they pulled back and said, okay, we've got to go back to the drawing board here. Let's write ourselves a 6-month extension, and I believe that 6-month extension expires November 11th or around November 11th. So any speculation on when we might see a new rule from the DEA? Because I think that's a hot topic for everybody. If all of a sudden you mess with a provider's ability to prescribe,
Right.
that can really affect their
So
ability to deliver care.
if you look at that proposed rule as originally written, and introduced, you look at there's an underlying theme, right? The theme is the provider is going to be covered to prescribe Schedule 3, medications or greater, right? So controlled substances, but they want some kind of history in terms of the prescriber's relationship with that patient in person. So, and they lay out basically steps for that to occur. Now, state medical boards are going to be interested in that too. I mean, there's an ethical piece of this for physicians, and as they consider, what the state boards of medicine are going to do, that's an important piece in all of this. But the DEA is trying to figure out how do they put some protections and enforcement around this, so that the telehealth legislation and allowances under regulation are not abused. And I think that's understandable. And I think they have taken all those comments. My understanding is that they have withdrawn that, taken it back in terms of in-house, and their leg affairs shop is kind of working through it now, trying to figure out, working with stakeholders and certain members of Congress to try and figure out how do we figure this out going forward. They could release it in 60 days, 90 days. I think the understanding is that they're withdrew it for 6 months, and they're going to shop it and clean it and then put it back out there. It could, easily get dropped again at the end of the year, perhaps, maybe during the Christmas holiday. Agencies love to drop regulation during the holiday periods, which drives everybody, the rest of us, crazy. But so we could see it back around Thanksgiving or Christmas, I think.
And so they could really just write themselves another extension, right? There isn't necessarily any penalty if they don't have this figured out by November 11th. They could come out November 10th and say, we're going to take another 6 months.
Right. They could.
Okay. Now, in 2019, Congress acted and wrote legislation that passed and that was signed into law that the DEA had to establish a special registration for telemedicine. And the DEA just ignored that. Is that how does that work? How are
Is
they
that
able
kosher?
to? How,
Is that kosher? Is that what you're asking?
yeah,
Um,
how does it?
how do you just give the middle finger to Congress and say, I'm not going to do this?
Yeah,
Um, agencies do this all the time. They test the will of Congress on a variety of issues. And this happens from time to time. I think, until congressional leaders grab a hold of it and say, wait a minute. We never intended for this to last this long. There's a lot of maneuvering that Congress has in order to get the agencies to line up on congressional intent. And, honestly, this is just one of those where stakeholders have to come forward and remind Congress, hey, you put this in writing, it's in legislation, you put an enactment date on it. It needs to be enforced. And, and that's basically the bottom line. And then they've got to move on it. And it takes, it's a big barge. So the barge doesn't move very fast, it moves slowly.
so they left the piece out that said, you have to do this by this date or we're no longer going to fund you.
So I need to go back and look at that. I'm sure there's, enforcement dates in there and pieces in there, but yeah, they can choose to ignore it, or they can choose to pretend they didn't read it. Like, oh, Congressman, was that there? I didn't see that at the end of the legislation.
It's like moving heaven and earth to get something through and into law, and then they can just ignore it. But well, hopefully we'll see something that is far better, and hopefully we'll see that before November 11th. So
I think there's been a couple of hearings on the House side. Well, I believe 2 hearings on the House side, 1 hearing on the Senate side on different pieces of healthcare, telehealth legislation. Next year, the first quarter of the year, probably early February and March, I think are going to be seeing more activity, more serious activity around those pieces of legislation that have been moving through the process. They begin to go through a process of where, all right, what pieces of those bills can we take together, put into a major piece of legislation that's going to capture everything, and then we kind of move it forward.
Got it. Well, some bigger news. The CMS physician fee schedule for 2024 was announced, and we've done a lot of other webinars because this is just such a fluid topic right now. We've done other webinars. We went through the entire 2024 extension, and we had outlined, look, here are the things that CMS is going to have to align with, right?
Mhm.
So it wasn't necessarily enough just have this 2024 extension. There were a number of things that we outlined that we're going to need to appear in the proposed physician fee schedule for 2024, and it does look like that CMS has aligned well with the 2024 extension. Do you have any comments on just high-level comments on the physician fee schedule before I'll actually dive into some of the details and read some of the telemedicine specific details for everybody that's attending today?
So, again, they're trying to grapple with, number one, how does the agency pay for it? What does the model look like that would work best? Is there going to be some kind of hybrid rate which works for non-facility payment? And I think that's, part of what they've been toying with and trying to fool with is what is going to be the best payment model for non-facility and in-facility virtual visits, and how are we going to handle that? What kind of guidelines are we going to put around that? So, yeah, that's, continues to be an ongoing issue at CMS.
Got it. So let's dive into some of the details for everybody that's in attendance today. So let me just hit some of the highlights. There's, this is, we're just hitting on some of the highlights for telemedicine. This isn't a comprehensive review of everything in the physician fee schedule, but because it's a massive document that gets put out. But they aligned with the 2024 extension, basically saying that the patient can be at home and you don't have to be in a rural area. They maintained the expanded list of eligible Medicare providers that are able to offer telehealth. So folks like physical and occupational therapists, also FQHCs and rural health clinics.
Can I jump in for just a moment?
Yeah.
I think one issue of their consideration right now is social workers, those that are involved in social services for the elderly, being in a hospice unit, for instance. Would they fit the protocol and the model? And if so, I mean, that's one thing as to how will social services be reimbursed if they're allowed to be able to work in a virtual setting. So
interesting. Okay. And yeah, there's a lot of travel involved in that type of work too. So virtual, I think could have a lot of impact there. Let's see, they in the 2024 proposed physician fee schedule, we also have the temporary permission for certain services to continue to be provided via audio only. So
right.
that's in there. You have the temporary suspension of the in-person service requirement prior to the delivery of mental and behavioral health services through telehealth or audio only. It says this suspension applies when the geographic requirement is inapplicable. It says the service occurs at the patient's home and the patient is not being treated for a substance use disorder. So there's some specifics there around that in-person requirement, but I think for just to summarize, it's basically a continuation of what's been in place. And then basically, I think one of the most important pieces is payment parity is still going to be in place for 2024. So that's a big piece, and we're gonna come back to that piece.
Right.
Any comments before we hit some of the other highlights?
No, I think, I believe that much of what CMS is doing is really trying to figure out how much of the aspects of the delivery of telehealth services needs to be codified. What was necessary for the transition to get us through COVID, and then what is necessary and should be staying in place for Medicare beneficiaries going forward. And there's, as I mentioned to you earlier, there's a lot of data collection that's going on right now, and they're trying to figure out what are the trends, what are patients actually utilizing today, and are they continue to utilize them going forward? So how are they best utilizing telemedicine features now that are paid for by Congress or by CMS? And then how are they going to, is that going to be the same going forward, or is it going to trend up, going to trend down? And so, they're really at work trying to get their arms around this. Commercial plans, health plans are doing the same thing. The Blues plans around the country and some of the others like Aetna and United have been out in front, really more so than the federal government, on putting arms around, and a structure in place around what their telehealth benefit will look like going forward and what their members are entitled to and not. So I think the hope is that it'll all come together relatively soon here in the next year, and it'll all be somewhat the same. I think you might find, interestingly enough, is that some commercial health plans may have more features and benefits for telehealth because they believe overall it's going to be less costly. So if they can move a patient in that direction, then, it makes sense, from a cost standpoint.
Yeah, I think they were seeing that even before the pandemic. And I think, Cigna, as an example, prior to the pandemic, came out pretty early and said, for behavioral health, we're going to cover telehealth across the board and what have you. So it definitely seems like they've been a little ahead of the curve there. Here's some of the other highlights
Okay.
relating to telemedicine and the physician fee schedule. So there's a continuation of the telephone evaluation and management codes. Now, we're gonna talk about this in a little bit more detail in the future, because this may change in 2025. So then we've got the originating site facility fee. They just updated the price to $29.92. You have audio only for the periodic assessment for opioid use disorder. So any opiate treatment programs, which I think has been a big initiative by the federal government to do more to support that. So there's a continuation of audio only there. And then let's see here. There's some proposed updates to the telehealth indicator, planning to use the most recent codes that identify a clinician as providing services via telehealth to keep current with any changes. So there's just some details maybe and slight modifications on how some of these things are going to be identified when it comes to actually submitting the claims. So there is a great summary on the Center for Connected Health Policy website for anybody who wants to get the telemedicine specific information out of the proposed physician fee schedule. Otherwise, I'm sure a lot of the associations and whatnot cover some of the summaries of that. But we're I believe we're in the comment period now. So now's the time to comment if
Right. I believe the comment period is open until September 11th, I believe.
Okay. So good time to make your voice heard if there's anything in there that anybody needs.
Yep.
So before we get into the last topic and then our Q&A, we wanted to have our first of two poll questions. So Michael, if you want to initiate the poll, the question is, where are you getting state and federal information from? Are you getting your information primarily from Center for Connected Health Policy, news and media, associations? Maybe you have some internal resource in your organization that's responsible for anything regulatory or other. So if you want to go ahead and answer that question, and then maybe we can give everybody another 20 seconds or so, and then Michael, maybe you can close it and share the results with us while we are waiting for the results to come in. We'll have a little bit of time here for Q&A at the end. So if you have any questions related to some of the topics we've already covered, feel free to start getting those questions in now so that we don't run out of time to get to everybody's question. The sooner you get them in, the more likely we are to have time to answer that for you.
All right, I'm just going to end that poll, and it looks like we have a three-way tie. The Center for Connected Health Policy, associations, and other were all at 29% of the votes, and then there was a one vote for news and media. So that's where it came up, nothing on internal policy resource.
That makes sense. I think those are good
Mhm.
places to get your information from. So let's switch gears a little bit. So we had talked about this a little bit in some past events, but the AMA recently, so the AMA, I think most people who attend know that they copyright and maintain all of the CPT codes, and they came out with about 17 new telemedicine codes. And then it looks like there's the elimination of audio only or telephone codes. Now, these wouldn't go into effect until 2025.
Right.
But the fear is around payment parity, which we touched on. So we touched on we can kind of maybe start with payment parity, but I think this is the most active time for telemedicine. We don't have permanent legislation yet. So there is time to get involved and shape permanent legislation. So I think this is an important topic for people to get involved, make their voices heard on, because we don't know what 2025 is going to look like yet. But so John, what do you recommend? How can people get involved that want to get involved and have a say and be able to shape permanent telehealth legislation?
Sure. So, the whole coding process, it's crazy within CMS that they delegate a lot of that to the AMA, but they do, and they have done it for a long time. So the beginning of that coding process, well, all of that coding process, which is run kind of, through the Center for Medicare, is done, hand in hand with the AMA. The only caveat to that is that legislation can direct and usurp, basically override what those codes do or how those codes are written. So getting involved is important. Now, there's a couple of ways to do that. I mean, as physicians, as organizations, if you've not been involved in the political process or the legislative process with your state medical associations or your professional societies, now is the time to do it. There are various coalitions in Capitol Hill right now that are addressing these issues. Some of them are addressing them on behalf of larger organizations that are providers, large multi-state or national providers in the space. They may not necessarily reflect the views of physicians or physician groups at the grassroots level. And so it's important to think about, would you be willing to be a part of a coalition? And if so, to what degree? Would you be willing to come up to Washington and spend a day talking to lawmakers and to legislative staff helping shape policy? Are you willing to make calls to legislative staff in your home district? Much of this begins back home where you live and work. And so I mentioned to Matt earlier today, I was visiting with Brett Guthrie, who's a congressman from Kentucky, just a couple of weeks ago, and he is the subcommittee chairman for the Health Subcommittee on the Energy and Commerce Committee, which has one of the two committees in the House that oversee healthcare. And I asked him, are you hearing much from your own folks at home? Are your hospitals, are your healthcare providers, your docs, calling in and talking to you? And he says, I really don't hear much from my own district. Now, he says, I'm hearing a lot from folks across the country, but not from my own district. Well, if you care deeply about telehealth and you believe that there are pieces of this that are really important for your practice and for your patients going forward, it's important to get involved. And it's not hard. I mean, it's easy to pick up the phone, call legislative staff in the district office, have a conversation, request a meeting, let the doc go down and have a face-to-face conversation with the congressman, let them know how you feel, the pieces that are important. The other parts of that are working together in an organization like a coalition. In Washington, there are coalitions that are created every day. Most of them have a lifespan. They will work to either kill a bill or pass a bill. And when their feat is accomplished, then they all fall apart and go back to life as usual. So, that's certainly something that we could help put together and help direct folks who might want to be interested in being active on this issue. Being active on the issue doesn't, if you're not comfortable coming to Washington, you don't have to be, you don't have to walk the halls of Congress, but it is important for lawmakers to hear from providers who are on the front lines and who are interacting with patients every day to the benefit of what this legislation could provide. And so I throw that out there and say something for consideration for you.
So, I mean, I like the idea. I think the first thing people think about is it's going to be too expensive, right?
Right.
And you start to think about, lobbying. You hear these amounts thrown around in the media. What are we talking about when it comes to a coalition? And is that the right assumption that this is just too expensive? This is going to be a very expensive proposition, or is that not the case?
Right. So coalitions, are built of all sizes, right? So it depends on how you build it, but I think you could certainly build a coalition of providers that want to work on telehealth legislation that will cost anywhere from around a $20,000 to $25,000 a year investment less. You can scale it, up or down. You could put together a coalition with 6 or 8 or 10, on a steering committee. They're willing to pay X amount. And then you have sustaining members that are somewhat going to be involved in helping direct policy. But there's ways to do it in a cost-effective format that still allows you to have to be in the game and help shape policy at the federal level, and yet not kill yourself financially.
Makes sense. Well, let's use that for our last poll question here. Michael, if you'll start the last poll question. Just kind of curious if that's something folks would be interested in, having a more formalized coalition that, as John said, there's not a lot of representation from different provider groups. A lot of the representation is from large organizations. And John, I mean, is this true? I think probably the folks in Washington would are they kind of sick of all the larger lobbying groups? I mean, don't they want to hear from regular size companies, medium sized companies? I mean, what's your take on that? And we'll give everybody a chance to answer this question here.
Sure. I mean, they hear from health plans and large hospital systems all the time. I think what they really want to hear from are physicians and providers at the local level that are in the game in their local communities. I think, health plans and large hospital systems and other players, all have mixed interests, right? So the Optums, the Uniteds of the world all have, varying competing interests. When you talk about physicians and other providers in this space, they're more interested in, how would this legislation impact them at the local level on a regular basis? How is it going to impact the care that they are providing to their patients on an ongoing basis? And then they become, what ends up happening in many cases is they become an ongoing resource for that congressman or that congressman's office or that senator's office. where from time to time their health counselor may pick up the phone and say, doctor, gosh, can you give us your views on this? We're going to send it, fax over a piece of legislation. We'd love to hear what you think about it. And then you become a trusted local resource for policy shaping going forward. And that's a wonderful place to be. I've been working with physicians now. I started my lobbying career with the State Medical Association in Florida in the early 90s. And, really, they are the salt of the earth in terms of providing care. They're on the front lines every day, working with patients and meeting patient needs and seeing all kinds of ancillary issues that go along with it. So, your local doctor, I think, or provider of any other facility. I mean, whether you operate a behavioral health facility in your local community, a hospice, a home health, any of those are, these are all important, aspects to the delivery of care. And lawmakers want to know, they want to hear it from you directly.
All right. Well, Michael, all right, we've got some results. So looks like we've got a lot of maybes. So I think it's something that people are clearly interested in, but there's probably a lot of remaining questions around that and how that would work. So that would be exciting to get more people involved. Well, let's transition to our Q&A. If you are in the audience and you have any questions, any other questions specific to the coalition or other areas that we've covered, feel free to start putting those questions in now. And then, John, I just wanted to touch on quickly as well that you've done some other work for some organizations around audits and helping them navigate any maybe audits or any issues there. Do you want to sort of describe that, and I will sort through some of the questions here?
Sure. So as most of the folks on this call know, CMS has a division called the Center for Program Integrity, which looks at waste, fraud, and abuse. And regularly they audit providers on a whole range of issues related to the Medicare guidelines and their ability to adhere to those guidelines. A lot of it is around reimbursement and to the actual medical necessity of claims that are filed. And we've been working with providers of all sizes over the last 10 to 12 years now as they make their way through this audit process, beginning with the UPICs, then going with the MACs, and then going through the QUICs. We've had a 97% success rate. We've worked with providers of all sizes, the largest behavioral health company in the country, the largest home health company in the country, down to regional players in all spaces and local providers. So if anybody's here on the line that are caught in that RAC, MAC, UPIC, hellacious audit process, reach out and let me know if we can give you a hand.
All right, appreciate that. So I've got a question here around the coalition, and what type of time commitment might an organization expect if they were to participate in a coalition?
Right, it depends on them, and their volume, their capacity to be involved. I think if you want to be involved at a steering committee level in terms of helping direct policy development and really weigh in on key areas, I think probably a couple hours a week. It just depends on, how it rises and falls and fluctuates. So much of the work is done, at the staff level by myself and a colleague, and then we would be reporting out and then asking for, physicians and members of the coalition to be able to get involved and do different pieces, but to help us in terms of forming policies and alternatives when we're looking at legislation that's before Congress. So I would say it kind of fluctuates. There's not a hard and fast number to put there.
There's a number of different questions here related to the coalition, but like what kind of structure would it take? Like what are just maybe some more of the higher level details, just to give everybody a better sense
Sure.
of how it might be structured and work?
So I've been involved with, I don't know how many coalitions, probably a dozen on Capitol Hill, created several, and then we've been a part of several on behalf of client matters. Typically it will, there'll be a steering committee level. So you'll have folks that are willing and able to pay in at a higher level that will be more on the front lines of helping develop that policy. And then you'll have the policy direction, and then we'll push down to that mid-level membership, everything that's moving forward and how, what the policy areas look like, and then ask for input, guidance, how to formulate it. At the end of the day, you come up with a direction that everybody is happy with, and then you move forward. I don't think it's too cumbersome. It's not, you develop a coalition to be, to be effective and not to be like cumbersome and complex. So I don't know if that's helpful. I mean, we'll have something drafted up here in the next couple of weeks that we can get out to everyone.
That'd be awesome. Well, it looks like some of the other questions were more housekeeping related, and so we were able to get those answered directly. So with that, I think we can wrap up. So I just want to thank you, John, for participating and bringing your wealth of knowledge and experience in Washington to today's webinar. I'm sure everybody found it informative, and yeah, just hope everybody enjoyed it, and hope everybody has a great day.
Thank you. Have a great day.